So indeed, I think we already had a great picture of what's happening in the shower drawn by Mark and Siliwe. And the goal would be is that I now zoom out a bit more on what's happening on lay counsellors in the region within Southern Africa. And that's where the title comes from, HIV/TB counselling, who is actually doing the job in Southern Africa. So this image, you have already seen it by Mark. I would really like to use it. Which is actually showing in numbers what the 90-90-90 goals actually should mean. And on the top, you can see what the goals are, and at the bottom, you can see what the reality is. So there's clearly big gaps in what we want to get at and where the situation is today. And so that's why different strategies have been put in place in our projects, like task shifting, decentralization, integration of HIV services. And there's one specific strategy which I want to talk about, which is patient education and counseling. As Siliwe already talked us through, patient education and counseling plays actually an important role at different drops in this HIV cascade. She talked about HIV testing and counseling. I don't see the thing. HIV testing and counseling, which actually tries to address this the first big gap or drop in the cascade. Secondly, there's art initiation counseling. So when people are supposed to start treatment, that's where Siliwe and her colleagues play an important role to explain patients what is it about and how can you adhere, and to ensure that these patients actually reach a suppressed viral load. Then, to ensure that people retain in care, we have set up different patient-centered art refill models, of which I'm going to talk more about this afternoon. And again, that's where education and counseling plays a role to ensure that patients are aware of these models, that they know what is asked from them in these models, and so on. So the counselors play an important role in facilitating these models. And then at the end, you see enhanced adherence counseling, which is what we call patients who are red flagged, patients who haven't been able to reach an undetectable viral load. We do interventions with them to see, okay, what's going on now here? How can we help you? So that's where counselling and education plays an important role, and also, as you see on the left, also counselling and educations for these high-risk groups. As Siliwe was talking about, these pregnant mothers who are HIV positive, or these young adolescents who are HIV positive but are actually not even aware that they're HIV positive. So that's where is also a key intervention for our counsellors' teams. Now, of course, in Southern Africa, we have the big question is who will actually do this? If you look here on this graph, this actually shows the number of healthcare workers available according to patients. On the right, the most right-hand column, you see on the down there, this is what WHO actually recommends, to have at least 230 health workers for 100,000 patients. And this is what the reality is. Malawi, only 36 healthcare workers. Take Mozambique, 44. It's going better as we go down the line. But mainly the issue is, okay, if there's already that few healthcare workers, who will then take up these supportive tasks for our patients? And so that's where this whole idea came of lay counsellors. So to give it a bit of a definition, who are we talking about? These are actually cadres who perform these patient education and counselling tasks, mainly at the health facility. And we have been training these people to do these tasks, but they don't have any tertiary or higher education to do this. So mostly we talk about people who have been through secondary school, who come from the same community, who may be HIV positive themselves, and who have been trained on this supportive tasks. So we decided to invest in them because actually they need less of an extended training if you compare that with a nurse. They're actually it comes at a lower cost to implement them, and we can also retain them easier because they come from the same community and understand the issues that our patients face. But what did we see in our settings, not only in KwaZulu-Natal, who had recently decided to withdraw the councillors, but we actually see that we're caught up in a vicious circle of lack of recognition and lack of financial support for these cadres. So on the one hand, we see, okay, there's a lack of national policy. Ministries of Health tell us, okay, we don't have enough resources to actually work out a proper policy for these lay cadres. This results on the ground in a lack of supervision of these cadres, because it's not really clear who's going to do it, and a lack of sustained financial support. So partners may come in and they're going to fund that cadre for a number of time, and then it stops, and then the question is, okay, who's going to take this over again? And all of this is, there's a lack of recognition of them. Again, donors say, okay, we're willing to support this temporarily, but you need to show us a plan of how you're gonna sustain them. So you need to have a plan of recognition and so on. And so it gets caught up in this whole circle again, because the Ministry of Health doesn't have a plan, because they say we don't have resources. So it's we're making circles there. So actually, to look a bit more in depth at the situation, that's where everything is here in this report. We did a number of country studies to review and compare what the situation of these lay cadres is. So we did a lot of discussions with country-based staff of ministries of health, donors, NGOs. We looked at policy documents and so on. Mainly in countries in Southern Africa, Lesotho, Malawi, Mozambique, Swaziland, South Africa and Zambia, and Zimbabwe. And then we also looked at Guinea, because we're there as well as MSF, so we had easy access. But they're not Southern Africa, if you would be hesitating on that. So what did we do? We looked at some general indicators of what is their general country profile. We looked at harmonization of these cadres within the country. We looked at the national strategies that may or may not exist. And we looked at how these cadres were or were not financed in these settings. Now, what did we find? Regarding harmonization, basically you have to imagine, I just came back from Malawi, and we have a bunch of lay cadres there floating around. Some are called mentor mothers, others are called peer educators, others are called psychosocial counselors, others are treatment literacy agents whatsoever. It all depends a bit on which partner is intervening and how they like to call it, which is a bit of a worrying situation. Luckily, the situation is not like that in every country, so we do clearly see some progress in trying to standardize all those different cadres that exist, and try to standardize job profiles and training. Yeah? And that's where ministries of health actually play a very important role to take on this leading role in doing so. In general, however, we do see that the biggest focus that is given, or the biggest attention that is given of these lay cadres is towards testing and counselling, so this first gap in the cascade. However, this stands in clear contrast to this lack of attention on adherence and on retention in care, which is also needed. It's not just about getting them starting in care, but it's also about keeping them in care. And the challenges which Siliwe actually talked about were a lot around this adherence and retention in care, for which lay counsellors aren't often recognised their full role yet. In the different countries we saw there's this tension between, should we go for a more generalized cadre, like Malawi, for example, has a community health worker cadre which exists, and which they said, okay, this task of HIV testing and counselling, we're going to include that in their job profile. So that was on the one hand easy because it was an existing cadre, but this cadre is being, well, we call it task shifting, but you could call it task dumping from time to time, is getting loads of tasks on their shoulder. Everybody gives their task to them, and in the end, honestly, those poor guys, I don't know how they do it and how they are able to combine all of what is asked to them. And so some settings rather said, okay, we're gonna go for a specialized cadre. So Zimbabwe, Zambia, for example, has a specialized lay counsellor cadre who has a clear, restricted standard set of tasks. Another tension which we saw is this tension between should they be community or facility-based. In most of the settings, these people work facility-based, but now there's also a clearer recognition that we need to go for like community testing strategies, as Mark also showed. So we'll also need to think of how to create that balance between facility and community-based amount of time, where do they spend it and how are we going to frame that? So harmonization, there is still something to do, but we've already came a big way in moving forward and harmonizing this further. Now, what can we find back in national strategies? Actually, national guidelines on how to support adherence and retention in care are only emerging now in the last year in a few countries. South Africa is busy launching their adherence and retention guideline now. Zimbabwe also did that this year. And these national policies are somewhere also needed to show the importance of such patient education and counseling interventions. National task shifting frameworks, so which tasks can we give to a lower trained cadre, are mostly lacking in a lot of settings. So there's no clear vision on what do we want to task shift to these lay cadres, what is feasible, what is not. And we see that a lot of countries are actually pushed to go from short to long-term strategies, but we clearly see that there's a need for some interim solutions, because it is quite hard to ask a country within 3 years ensure that this new cadre suddenly now gets recognized in your Ministry of Health payroll. In terms of financing, there's different contracting and financing options that exist, not only within the Ministry of Health staff establishment, but also outside of it. But countries face multiple constraints. There's wage bill policies, which actually put a maximum on the amount of people that they can enroll on the Ministry of Health staffing. Often they struggle with pre-education criteria, and these pre-education criteria are often a lot higher than the ones we require for lay workers. There's issues of career progression or of career path, and the donor condition to actually fund certain staff is often you need to absorb them, and that's where the time frame is often not realistic. So I see my time is limited, right? So I'm not going to go through all of this, but I think it's just important to show that there's different contract types which countries have experience with, and it's which can be really creating a new cadre and integrating that in the MOH staff establishment. But it can go as far as having, like in South Africa, in Western Cape, for example, the Ministry of Health actually subcontracted an NGO to train this cadre, to hire this cadre, and could avoid a lot of stumbling blocks into having to integrate it. So there's a lot of options existing, and they're described in this report. Sorry, let's go through this. Voilà. But in conclusion, I want to say lay counsellors do play an important role in addressing the gaps in this cascade, whilst their position is often at stake. Definitely, how should we integrate them? There's no one size that fits it all. Countries have different strategies to finance and to support lay counsellors, but it's definitely clear that while they are trying to figure out which is the best way to do so, to integrate them, there is really a clear need to continue their donor support, to continue the donor support to human resources for health, to ensure that we have a sustained financial support of these cadres, and to avoid situations like now in KwaZulu-Natal, where suddenly the lay counsellors are phased out, and people like Siliwe, who are supposed to mentor people, are actually seeing patients just because there's a lack of resources there. Thank you.
Thank you, Saar.